Good afternoon and welcome to First Presbyterian Church and to the William R. Law's Peacemaking Lecture for 2018. My name is Felipe Martinez. I'm pastor here at the First Presbyterian Church, and we are just delighted that you're here to listen to a very important conversation on healthcare access in our country. I want to remind you or let you know that if you look in your programs, you have a 3x5 card. We are inviting you to write a question on a card, and then at the appropriate time, we will have ushers collect those, and then those questions will be brought to the front, and then we will be able to get your questions asked, and Professor Quigley will answer them. I also want to remind you that this is an outreach of the Presbyterian Church, and it's only made possible through the donations of people like yourselves who encounter these lectures and find them to be helpful for the public dialogue in our city. So I invite you to use these envelopes that we have here to place a donation, which you can drop off on as you exit. There will be people there with baskets, or if you prefer to write a check later on this week and mail it to us, it's all pre-addressed, and we would appreciate that. It's my honor to welcome Professor Fran Quigley to First Presbyterian Church and to introduce him to you. Professor Quigley is a clinical professor of law teaching in the Health and Human Rights Clinic at the Indiana University Robert H. McKinley School of Law. His students in the Health and Human Rights Clinic advocate for the rights of the poor, with a special focus on individual and systemic barriers to accessing health care and the social determinants of health. He coordinates the group PFAM, which stands for People of Faith for Access to Medicines, and you can find out more about them at their website, pfamrx.com. He is a graduate of Hanover College, a fine Presbyterian institution. You have alumni from both of your alma maters, Hanover and Indiana University. Hey. In his latest book, which is entitled Prescription for the People, An Activist's Guide to Making Medicine Affordable for All, which was published last year by Cornell University Press, Professor Quigley argues that medicine should not be treated as private property, but instead it should be considered a public good, like education or infrastructure. In that particular work, he advocates for a shift in the global and U.S. approach to developing and providing essential medicines. Globally, 10 million people die each year because they are unable to pay for medicines that would have saved them. Patients and activists are aiming to make all essential medicines affordable by claiming them as a public good and a human right. Today, Professor Quigley will be speaking specifically about the issue of access to prescription medicines and will be making a broader case for a single-payer healthcare in the United States. Friends, I ask you to join me in welcoming Professor Fran Quigley.
Thank you, Reverend Martinez. Thank you, Dr. Hale, and to all the folks here at First Presbyterian for inviting me. And wow, looking at the list of people who've given this lecture ahead of me, this is big shoes to fill. However, I don't see any Hanover alums there, so I think maybe it's time. So today, as Reverend Martinez mentioned, I'd like to talk about the path to healthcare for all, and I'd like to suggest that we consider three different stations, way stations on the way towards healthcare for everyone. And the three stations I'd like to talk about are, number one, is to understand the obstacles in our path because they're significant to have everyone in our communities get access to healthcare. And the second is understanding that there is, though, a map to our destination that our brothers and sisters around the world have already written out for us. And then the third and final way station I'd like to discuss, and hopefully we're going to leave plenty of time to hear from you and have a conversation, is to consider what steps we're personally called upon to take along that path. So when you talk about healthcare, and Reverend Martinez was kind enough to read from some of the material we have about people of faith for access to medicines and at the law school in our clinic. And there's a lot of very disturbing statistics out there, and I'll mention a couple of them. But I'm not going to start with statistics. I'm going to start with the story of Alec. Alec Rayshon Smith, I've come to know, my wife and I have come to know his family. His mother, Nicole Smith Holt, stayed at our home a few months ago, and his mother and his father visited our home a little bit more recently than that. And Alec was a young man who lived in Minneapolis, Minnesota, Midwestern. He's a type 1 diabetic, and persons with type 1 diabetes, as a lot of folks in this room know, must have insulin every day to survive. People with type 2 diabetes oftentimes need insulin to survive. Persons with type 1 diabetes always need insulin. As they say, it's like oxygen for the rest of us. They must have insulin to survive. Alec, as a type 1 diabetic, turned 26 years old last year. Now, in the world of U.S. healthcare, that's a pretty important birthday. Some of you know, I see some young heads nodding. I see some other folks who have adult children, you're nodding, because 26 years old means that's the age when most kids, young people, get kicked off of their parents' health care. And Alec was like a lot of 26-year-olds in the United States of America, and that he worked full-time. He worked as a restaurant manager, worked hard, but he didn't have very good health insurance through his job. And his mom, and he knew this was coming as a person with type 1 diabetes with this serious chronic illness. It's treatable, but chronic illness needs to be treated. They did the research and looked to see what it would cost him to get health insurance in the United States of America in 2017. And they found that the best policy they could find for Alec cost $450 a month as a premium, and then a deductible of $7,600. And that meant, of course, that Alec was going to have to pay out of pocket $7,000+ before he was ever going to get any coverage. So he made a decision, which seemed at the time to be a very rational decision, which was he was going to go without insurance as he was paying out of pocket anyway. He was going to pay for his medicines out of pocket, and he was going to keep working but look for a job with better health insurance. So that's what he did. In the first month that he was off his mom's health insurance, June of 2017, he went to the pharmacy, and he had somehow, as mom still says today, I don't know how on his salary he managed to do it, but he had somehow scraped together $1,000 and put it in his account for what he thought was going to be the cost for his insulin and supplies for the month, $1,000. But the price of insulin has gone up and up and up. Even though it's the same formula as 20 years ago, a vial 20 years ago, for the exact same insulin today, it costs about $30. Now it costs out of pocket for somebody like Alec upwards of $300. So he went to the pharmacy, and what he thought was going to be a $1,000 bill for a month's supply of insulin and his supplies was $1,300. And he did not have $1,300. That's the last that anyone knew what kind of decision Alec made. He left because he couldn't pay for that amount, and apparently he went home and started rationing his insulin. About 40% of persons with diabetes have rationed their insulin. But it's dangerous. It's so dangerous that on June 27th, 2017, Alec Rayshon Smith, at age 26, was found dead, alone in his apartment. He had died from diabetic ketoacidosis because he couldn't afford the medicine that was created almost 100 years ago to keep him alive. And of course, as I said, I've gotten to know Alec's mom and dad, and I tell that story, though, not just because this just happens to be somebody that come across in my life. I tell that story of Alec because it's not isolated, right? 1 out of every 5 people in our country, in the United States of America, do not fill a prescription each year because of cost. 1 out of every 5 people either do not fill a prescription or skipping medicines or cutting their pills in half or are not following their physician's orders because they can't afford to do so. If you go on the website GoFundMe, have folks heard of the website GoFundMe? Some of you are, some people are older like me. When I talk to my law students, they all know about all this, but Some of us at a certain advanced age don't necessarily know all that's going on online. But GoFundMe is what it sounds like, a fundraising website. GoFundMe each year has 250,000, 250,000 times people go on that site and beg strangers for their medicines, to help them with their medicines, to help them with their care, to help them to get the health care that they need to survive. By many different estimates, tens of thousands of people each year in our communities in the United States of America die. Like Alec, they die because they can't afford health care. And the suffering is much broader than people who have pay the ultimate price like Alec did. You know, we probably know in your own communities, maybe in your own networks, maybe some of you have gone without care because we can't afford it. Or we've got family members or neighbors or colleagues who go without care because they can't afford it. So what I'm going to ask today is a little minimal amount of audience participation. On our first station on the path towards healthcare for all, I'd like to make this request. I'd like to ask all of you to do something with me, and that is to take this widespread suffering of people in our own communities who are struggling, who are suffering because they can't afford their health care, and lay that next to our faith traditions. Now, I'm guessing a lot of folks here come from the Presbyterian tradition, other folks come from other traditions, or maybe even just your own moral code. Because many of us in this room come from the faith tradition that has at its core the parable of the Good Samaritan, right? The obligation to provide care for the stranger, the struggling, sick, hurt stranger. Others of us probably come from other faith and moral traditions that have just as clear of a mandate. If you look in the Torah or the New Testament or the Quran, this is a core mandate of faith traditions. It's a core mandate of every moral code, and that is that we care for those who are struggling. The very first charitable hospitals in world history were Islamic charitable hospitals. And now in the Christian tradition, the Jewish tradition, and all faith traditions, there's all kinds of health care being provided, charity care all around the world. So I'd like to pose this question to you, and that is that when we've built our lives on these moral and faith traditions, does that make us called upon to respond to this suffering? And let me do a little self-disclosure in my own faith tradition. I was born in Indianapolis and baptized Francis Ignatius Patrick Quigley, and I was the 8th of 9 children. So maybe you can figure that out, right? I was born and raised in the Roman Catholic tradition. But nowadays I actually I attend a Quaker meeting in Indianapolis, and I've grown to really appreciate the Quaker tradition of posing a question and then having some silence. And then during that silence we think, or we pray, or you spend whatever you want to do with the time, and you feel, maybe the Spirit moves you, and we contemplate our next action. So now I realize that I'm brought here to speak. The idea of a lecture series is that I lecture, right? But I'm going to shirk my duties if I can for a minute or so. I'm going to ask you all to join me in a moment of reflection on that question. And that is, when you come from the faith and moral background that you do, are you called upon to respond to this suffering all around us? So I'm going to ask you to join me for just a minute or so to reflect quietly on that question. Thank you. Now, I must say the Quakers have had to train me to do this for a longer period of time, so I appreciate your patience if that's not your tradition. But we'll return to that question before we're done this afternoon. So that's way station number one, understanding some of the obstacles in our path and all the struggling going on all around us. The second way station I'd like to discuss is creating an understanding that there is a map to our destination that others, our brothers and sisters, have created for us around the globe. Because if you talk about a path and a destination and a road, the most daunting obstacle that we ever see is hopelessness, right? The idea, oh my goodness, we're never going to get there. And that's easy to do in the United States when we've had this legacy of people struggling to get access to health care for so long. It's like, oh my goodness, we're never going to get health care for all in the United States. There's powerful forces that are keeping the current system in place. We're never going to be able to overcome them. So I want to share a story. And the story is actually about a funeral, of all things, and a funeral in 1998. There's a little backstory to this. Again, it's good to have folks who are a little bit older in the room because you know something that maybe some of the younger folks don't. Is that, remember around the turn of the century in the 1990s, remember the HIV/AIDS crisis then? Remember what happened when people were diagnosed with HIV? It was a death sentence. There was nothing that was going to be done. They were absolutely going to die of this infection. There was no treatment available to it, and people prepared for their funerals. Then a medical miracle happened. With government funding, with US taxpayer funding, something called antiretrovirals were discovered. They were discovered to be incredibly effective at treating HIV. It was actually called the Lazarus effect, because people would be almost on their deathbed, or sometimes on their deathbed, and they get antiretrovirals, and they would get healthier, and they get stronger, and they gain weight, and within a few months they had no detectable virus in their system. And antiretrovirals turned HIV from a death sentence into a chronic treatable illness, and there are now people who have been alive for decades on end with what used to be a death sentence. Problem solved, right? Well, not quite, because what was happening in the mid-1990s when antiretrovirals were discovered was that there was a big problem in the middle of our healthcare system. And unfortunately, that big problem is still there today. And it's helpful to think about our prescription medicine system in particular in terms of three stages. What happened with antiretroviral drugs is the same thing that happens now with cancer medicines, with insulin, with asthma medicines, mental health medicines, hepatitis medicines, etc. And that is the three stages of this. The first stage is when the basic science, the most difficult, time-consuming, risky, least promising research is done. And that is done almost solely with US taxpayer dollars, with taxpayer dollars sometimes from other governments. $37 billion a year we spend with the National Institutes of Health, and that has created these amazing breakthroughs in cancer, in HIV, in mental health treatment, etc. This amazing research is done. That's what folks do at the universities, folks do in these academic settings, and it's funded by, I think, rightly so, by your and my taxpayer dollars. That's stage one. But stage two is something that never existed before the year 1980. In 1980, the United States Congress passed something called the Bayh-Dole Act. And I'm going to try really hard not to be a law professor nerd for you here. But the Bayh-Dole Act of 1980 was a massive, radical game changer. And the Bayh-Dole Act of 1980, for the first time in history, allowed the fruits of that federally funded, government-funded, taxpayer-funded research to be handed over to private companies. And not just the fruits of the research when it was promising, but the monopoly rights to that research for decades on end, at least 20 years, and oftentimes quite a bit longer. And when that monopoly right to a life-saving medicine is handed over to a for-profit company, the for-profit company with a monopoly right to a life-saving good is going to act like a for-profit company you can expect them to act. They're going to raise the price. Now, they do some follow-up research, do clinical research, and they do some other efforts. They spend more money on marketing than they spend on research. We can go into that if you want. And again, as Reverend Martinez said, I've written an entire book about it, so I can bore you to death on that for hours, but I won't. But the marketing does spend more than the research. But again, the for-profit companies acting as you would expect them to do with a monopoly, they're going to raise the price and raise the price and raise the price. And so what happened with antiretroviral drugs was, for the first time in history, this incredible life-saving medicine was in the hands, monopoly hands, of some for-profit companies, and they did raise that price. And the price they raised it to was $1,500 a month. Now, in 2018, $1,500 a month for medicine doesn't shock our conscience, but that was unheard of in the late 1990s. It was so high, but it set the path for what we see today, where again, the same phenomenon happens. The government-funded research, privately held, price goes up and up and up. So we have cancer medicines that cost $450,000. We have muscular dystrophy medicines that cost $750,000. That cost a fraction as much to make, don't reflect the research costs, etc. But that $1,500 price was up here. Now, there's one more stage of the medicine's process, and that is stage 3, where the largest purchaser in the world comes in and pays that monopoly price. And who's that largest purchaser? That's us again, right? That's the folks who paid for the research at the early stage, who handed over the monopoly patents in the middle stage. We pay that price through the Medicare program, the Medicaid program, the VA program, etc. And what happened with antiretroviral drugs is they were so incredibly effective and impactful, and people were suffering and literally dying, that we paid it. We paid that price. The US government paid that price, private insurance paid that price here in Bartholomew County and in Marion County and throughout North America and throughout Europe, but not in the global south. Right, because $1,500 a month was not just more than people with HIV could pay in the global south, it was more than their governments could pay. So people kept dying. And people didn't die by the thousands. People didn't die by the tens of thousands. People died by the millions. The millions of a completely treatable disease. Around that time, I actually traveled to Kenya. I ended up working for Indiana University. Some of you may know the School of Medicine has had a long-time partnership in Kenya. And I went to Moi University teaching in referral hospital at a time when the medicine was not widely available because of cost. And I saw it. I saw the bed after bed, and sometimes 2 people on a bed, and sometimes people on the floor between the beds, because the hospital was so full of young people dying untreated of a disease that they'd be living healthy lives in Columbus, Indiana, Indianapolis, Indiana, Michigan City, Indiana, what have you. And I distinctly remember there's a woman named Teresa, 32 years old, mother of 3, already a widow. Her husband had died of HIV, untreated. And she had what's called oral thrush. Oral thrush is like you have cotton in your mouth. She would look like she was skeletal. She was willing to talk with me briefly, but she died the next day. And you walk through the villages at the time in sub-Saharan Africa, and you would see grandparents raising grandchildren. And in the front yard, there'd be 2 stones or 2 markers, because that was mom and dad. Because that generation was dying untreated of HIV/AIDS. And that wasn't a mystery. I saw it. Other folks that did this work saw it, and the global health community was anguished by it, but also resigned to it. Because the pharmaceutical industry is powerful, and again, defending their own interests, understandably, they defended those patent monopoly rights and didn't allow generic medicines that were much cheaper to come into those countries. And the United States government, the Clinton administration at the time, I think this is a partisan issue, it was a Democrat administration. The Clinton administration fiercely defended those patent rights as well, and people kept dying and dying and dying. And the global health community was kind of resigned to it. It said, basically we should focus on prevention, because we're never going to be able to afford treatment. I mean, who's going to fight Big Pharma and win? Who's going to fight the United States government and win? And in fact, there was a well-known quote now on the Washington Post at the time by a global health official saying, this is pretty politically incorrect to say this, but we're probably going to have to just sit by and watch these millions of people die. But then there's that funeral that happened. And the funeral in November of 1998 had less people there than we have today. It was in South Africa. It was for a 41-year-old man named Simon Nicoli. And Simon Nicoli had died of AIDS, untreated, like so many others. But there was something different about Simon, and that was that Simon was in South Africa, and he had been an activist in the anti-apartheid movement. So a lot of his friends and family had been activists too. And they'd been going to funeral after funeral after funeral. And in this funeral one young man who was a friend of Simon stood up. His name was Zaki Akman, and he said, "Can't we at least try to do something? I'm willing to try to do something if you are. Can't we try to do something?" So then a few weeks later, in December 10th of 1998, Human Rights Day, 11 people, not a throng, not a mob, 11 people stood outside of St. George's Cathedral in Cape Town, South Africa, and they fasted for the day and they handed out pamphlets, or leaflets. And the leaflets said, "Can we at least try to treat pregnant moms who are HIV positive so they don't pass on the virus to their unborn babies, so that they have a chance at life? Can we at least start there and try to do that?" But from those humble beginnings, a movement started to grow. And more patients started demonstrating. And some of those patients actually committed civil disobedience by importing generic medicines that cost a fraction of the patent-protected prices. Now, they got arrested and the medicines got impounded, but it proved a point. And then the people who were being treated were started to be supported by the people who were doing the treatment. And physicians and care providers started to become part of this activism. There's a Ugandan physician named Peter Mugenyi, Dr. Peter Mugenyi, who I think should be a Nobel Peace Prize winner personally. Dr. Peter Mugenyi was the African success story. He was the brightest in his village, and he went over, he ended up being able to go to the UK, to England to get to medical school and get trained, and then he became a pediatrician with a successful practice in England, but he couldn't stay there because his entire generation was dying back home in Uganda. So he came back to Uganda to had to be retrained to treat HIV, but he couldn't treat anybody because nobody could afford the medicines. So Dr. Peter Mugenyi started speaking out. He actually tried to import the medicines himself, got arrested for doing so. So he wasn't successful, but he kept raising the issue. And more people started demonstrating in sub-Saharan Africa, and they started getting global allies. Folks here in the United States who'd fought for HIV/AIDS treatment joined them. Students joined them. Because this research that discovered antiretrovirals, that was federally funded research, was actually conducted at universities like Yale. And Yale students started saying, "Look, we're a part of this. We're complicit in protecting monopoly patents that are keeping prices artificially high, and people are dying as a result." And they kept engaging in things like mock trials, murder trials against the pharmaceutical companies. They disrupted, it was some pretty, edgy, disrupting activism. They disrupted Clinton administration activities, including when then Vice President Gore started running for president. They interrupted actually his actual campaign announcement. And they kept pushing. But just like the global health powers that be understood, the pharmaceutical industry and the United States government didn't roll over, right? The pharmaceutical industry filed a lawsuit in South Africa, filed a lawsuit in Brazil trying to stop generic affordable medicines from coming in. The United States government pursued really economically damaging trade sanctions against these countries for daring to try to get generic medicines in. Yet some of the poorest and sickest people in the world, supported by faith communities, some of the poorest, sickest people in the world kept it up. They demonstrated, they disrupted public hearings, they broke the law, and they agitated, and they litigated, and they pushed, and they pushed, and they pushed. And then they won. And then they won because that moral claim to health care, the same moral claim that we are taught in our faith and moral traditions, that same moral claim to health care, it turned out to actually be more powerful than the for-profit health care model. When that moral claim grew louder and louder, remember the politicians who had opposed generic access to medicines? Well, no matter how much the campaign dollars were, when they started to feel enough popular pressure, they saw the light. President Clinton, who had vigorously opposed access to generic medicines, did a 180-degree turn. So did Vice President Gore. Senator Jesse Helms had stood in the well of the Senate and castigated people with AIDS. And he repented publicly and said, "I was wrong, and I beg your forgiveness, and we need to make sure treatment's available to everybody." And when the politicians were not backing this price up anymore, the idea of what these pharmaceutical product prices are was exposed in a way that we now know, because there's Wall Street Journal investigations, congressional investigations, medicine prices have nothing to do with what it costs to manufacture medicine. They have nothing to do with what it costs to research medicine. They are, again, for-profit company acting like a for-profit company you could expect them to do. It's what the market will bear. And when it's a life-saving medicine, the market bears these enormously high prices that we see now, that we saw then with antiretrovirals. But when the pressure grew loud enough, the moral claim to healthcare grew strong enough, that house of cards of the prices, it came tumbling down. The price of antiretrovirals didn't drop 50%. They didn't drop 60%. They dropped 99% overnight. And Zaki Akhmat, that same young man who stood up in the small funeral and said, "Can't we do something?" He actually stood up on the steps of the courthouse on the day the pharmaceutical industry dismissed their lawsuit against Nelson Mandela and the government to try to block generic medicines in. And he said, "We have made the mightiest industry in the world and the mightiest country in the world shake in their boots." And they had. And today, there are 20 million people globally who have HIV or on antiretrovirals who are alive because of that moral call to healthcare. Now, I share that story like I share Alec Rayshon Smith's story, not because it's an exception, but because it illustrates a broader point. When it comes to healthcare, morally grounded activism works. Now, that's somewhat new for those of us in the United States, but our brothers and sisters around the world already know it. When we teach healthcare in the global context, and even sometimes in the US context in the law school, we put up on the screen usually this well-worn map, and it's a map of the world, all the countries in the world, and most of the countries are bright green. Those bright green countries are countries that have universal health care, irrespective of whether people can afford the care or not. Universal health care. Most of the world looks like that. All of Europe looks like that. Most of North America looks like that. Most of South America looks like that. Australia, etc. Asia, etc. The red countries are different. And mostly the red countries are very poor countries in sub-Saharan Africa and us. In us, the place where we actually spend more money per capita on healthcare than any place else in the world, but have these poor outcomes and don't guarantee care for all. So how in the world do these green countries pull off this miracle? How in the world do they do this? Well, at its core, it's not that complicated, because it's a lot like the way the antiretroviral prices came tumbling down. They've removed the for-profit middle of their healthcare system. They've removed the middlemen who are reaping windfall profits off the struggles of sick and desperate people, and all of a sudden healthcare becomes affordable. You think of it as a pipeline in the green countries and most of the world, especially the world that has the kind of resources we do in the United States. They spend money on healthcare, and there's a pipeline, and on the end of it is what? Healthcare. In the United States, we spend money on healthcare. We spend more money on healthcare than anybody else in the history of the world. And our pipeline has a big gaping hole in the middle. And the big gaping hole in the middle drains the resources out to for-profit companies, insurance companies, pharmaceutical companies, etc., who are making enormous profits off the money we, the people, are spending on healthcare. We have the poor outcomes on the back end. Those other countries have patched up that hole. Those other countries treat healthcare as a right, not as a for-profit, price-gouging commodity. So just like the HIV/AIDS struggle, though, again, no judgment here, for-profit company acting like a for-profit country, they're not going to give up that diversion in the pipeline without a fight, right? So we hear it every day. We're going to hear all the things, oh my goodness, if we have Medicare for all, if we have a single-payer healthcare system in the US, we're going to have care ration. They ration care in those other countries. Turns out they ration care less than we do in the United States. Healthcare is going to cost more. Our taxes would go up. Our overall prices go quite a bit down. We're going to have less choices of our providers. Medicare for all, we'd have more choices than most of us have now through the private insurance system. And we can talk about that more if you wish, because there's a lot of strong data out there. But the bottom line I would like to share with you is this humble lesson for all of us, is that our brothers and sisters around the world, they have already blazed this trail. They have already blazed the path to healthcare for all, and we can follow in their footsteps. So for my third and final way station I'd like to discuss with you, I want to circle back to our moment of reflection. What steps are you and I called upon to take now? Now, I mentioned the Good Samaritan story. And maybe it's not the perfect illustration because Alec Rayshon Smith wasn't 7th Street. Are we on 7th Street? Is that right? Alec Rayshon Smith wasn't on 7th Street, invisible to us when we walk. Oh, I'm sorry. Yes, I think he's 7th Street now. Alec Rayshon Smith wasn't suffering in a way that we could see him. Obviously, wasn't suffering in a way his family could see him, and they could have intervened. And most folks, including people in Columbus, including people in my neighborhood in Indianapolis, they're suffering in a way and we don't physically see them. We're not walking past them and not caring for them. And even if we do see them, we can't personally help millions of people. Even though our faith communities do respond very admirably with charity care throughout the United States, we still have this enormous injustice, enormous gap, enormous suffering going on. So maybe the Good Samaritan story isn't a perfect match, but remember, it wasn't meant to be a perfect match. It was meant to be a parable, right? And a parable, I think, lines up with a history that gives us plenty of examples what the path to healthcare does look like and the steps to be taken by those of us who are grounded in faith and moral traditions. What kind of steps? Steps like those taken by Southern Baptist ministers in the mid-20th century who marched arm in arm with rabbis, with imams, with Catholic nuns, and yes, Presbyterian ministers, and their congregations, and they marched and they defied racist laws, and they issued a moral call to action that led to the civil rights movement. I'm talking about steps like people of faith who wrote petitions, who convened talks and conversations like we're having this afternoon, and pushed their elected officials, and people of faith like Presbyterian minister John Rankin, who committed civil disobedience by running the Underground Railroad, and they issued a moral call to action that ended legalized slavery in this country. I'm talking about steps like those taken by a former Baptist minister, raised in the social gospel tradition. His name is Tommy Douglas. He became a leader in the Canadian Parliament and, backed by the faith community, pushed for health care for all. And he issued a moral call to action that created the system in their country that's not perfect, but a system where Alex Smith would not have died. A system where our brothers and sisters in Bartholomew County wouldn't go without their insulin, without their inhalers, without their blood pressure medicines. A system where people wouldn't be going online or putting plastic jars next to the checkout counter in the convenience stores begging for help because they're sick. So that's the good news. We have models. We have examples. And I have other good news to share with you. As we stand here on November 3rd, 2018, I think we're already blessed with the wind at our back along this path in several ways. We're blessed by the wind that's provided by the privilege we have of living in a democratic system where, for goodness sakes, our elected officials do need to listen to us. And they'll make changes if they hear from enough of us. And remember how the opponents, one-time absolutely dedicated opponents of HIV treatment, turned champions for it because they heard from enough folks. We're blessed by the wind provided by the privilege of a gift of our own connections in our community, in our congregation. The faith communities, not just in our traditions, but today in 2018 are making really strong statements for universal health care for all, separated from people's ability to pay, and that includes, you should be proud to know, Presbyterian Church USA has made some very strong statements and commitments to universal health care. And finally, we're blessed with the wind provided by living today in this time of opportunity, born out of crisis. Enough people are frustrated and morally challenged by the healthcare crisis that we have in our own communities, that if you look at the public opinion, if you look at the polls, 70+% of Americans want Medicare for all. A majority of Republicans want Medicare for all. This is not a partisan issue. A majority of Republicans want Medicare for all. A majority of physicians want Medicare for all. Business executives are taking a stand saying we don't want to struggle to try to find some bad insurance for our business workers there. Healthcare executives are saying that this is time to have a single payer system in the United States. We've got the wind at our back with public opinion. It's the time to act is now. So I leave you with an invitation to join me and others who are on this path, on this journey. And by others, I mean folks here, folks in this community. So I'd like to ask folks who are already doing this work in Columbus and Bartholomew County, folks with indivisible Bartholomew County and the Social Justice Committee here at First Presbyterian. So if you are a member of Indivisible or if you're a member of the Social Justice Committee here, would you mind raising your hand so others know? There we go. All right, we're preaching to the choir in significance of the percentage. But if your hand is not up, or even if your hand is up and you're surprised by some others, I invite you, we have a reception afterward, right? So we have a chance for folks to connect with each other and talk with others in this community who are already doing this work. So I'm grateful for you taking the few minutes of silence that we took to reflect already, but I urge you to not stop your reflection there. On behalf of the memory of Alex Smith, on behalf of the memory of all those who've died needlessly without care, on behalf of all those in our communities on this Saturday afternoon and this evening and tomorrow who are going to struggle because they can't afford their medicines, they can't afford their care, on behalf of all of them, I ask you to please join me in continuing to reflect on that question, on our personal answer to the question, which is on the path to health care for all, what steps are you called on to take? Thank you very much.
Have a seat. I want to remind you that we have given you cards, and I am really asking you to write a question on the card, and then when you have it, raise it so that one of the ushers will get it. I have a couple of questions that I will ask to get us started, but give you an opportunity to write because we really want to hear from you. Again, Professor Quigley, thank you so much for sharing your passion, your expertise, and the connections, not just with your passion for law, but also for your moral standing that helps us make these connections across those disciplines. I appreciate that very much. Let me ask you a philosophical question. What's the philosophical disconnect, you think, that prevents the U.S. government or U.S. voters from seeing public education and public health care equally as an essential human right?
And everybody can hear me with my remote mic, okay. Thank you, Reverend Martinez. I think that it's partly philosophy and partly history. We have a strange quirk in our healthcare history in the United States, and that is, of all things, World War II. During World War II, there was wage controls. And if an employer, and that might have been true of a Cummins, I don't know, others in the room may know, if an employer wanted to hire some good, effective people, they had wages they couldn't offer any higher than, right? If you wanted to hire a terrific engineer, you couldn't offer more than, whatever it was at the time, $30,000 or whatever. But what you could do is offer benefits. And so what happened was that the competitive edge came when employers would actually offer good health insurance privately to their employees. And that became somewhat the norm. At the same time, the rest of the world wasn't doing that. And so the rest of the world, especially post-World War II, was pretty, and the UK is a pretty good example of that, Canada is a pretty good example of that. They were pretty easy for them to pivot to providing health care as a right, just like education, publicly funded. And in the US, we have this again, a global anomaly of an employer-based healthcare system. So it's kind of stuck in this situation where private insurance companies contracting with employers grew to have skin in the game and grew to be very invested in keeping the system the way it is. So they've been powerful opponents, and again, understandably, for quite some time. So that's the kind of economic history. The second part, as you mentioned, is philosophically, of course, we're an individualist political culture here, right? It's we're going to make do on our own. We're going to figure this out on our own. We're going to earn our money for healthcare ourselves. Our individual employer is going to figure this out, et cetera. And of course, this is we know from Alex's story and all the others that we could share that with something that is so amazingly broad and pervasive as healthcare, just like with law enforcement or education, to your point, it doesn't work, and it doesn't work for a lot of people. So I think it's partly history and partly political, cultural philosophy of kind of the individualism in the U.S. And when there's opposition to something like single payer or Medicare for all, the rhetoric invokes that because it's like, oh, you're going to lose your choice, you're going to lose your independence, you're going to, the government's going to tell you what to do for your health care. And so that certainly is invoked by the opposition too.
Could Alec, the person you referred to in your story, could Alec have gone to the ER to get insulin?
He absolutely could have gone to the ER to get insulin, and a lot of people do. His story was, but going to the ER to get insulin, the people who do it, obviously that's a short-term stopgap measure. And unfortunately, some folks do. I don't know that no one knows because no one talked to him, no one had a chance to talk to him. But some folks who are type 1 or even type 2 who are low on their insulin will actually allow themselves to fall into diabetic ketoacidosis so they can go to the emergency room, so they can get a supply of insulin. But of course, that's a short-term fix. And as folks who are insulin dependent will tell you, they need it every single day of their life, just like folks with HIV need antiretrovirals. So. Yeah, and there's and some folks say, oh, what about the charity programs of the companies themselves, and all credit to whatever works for folks, but those are actually some pretty narrow eyes of the needle to get through because folks who are employed, who have access to insurance, oftentimes with big deductibles, can't qualify for those programs, and again, it's not a long-term answer for folks, but yeah, it's a heartbreaking. It's a heartbreaking story, and of course, as you can imagine, his parents, they're not poor, they're middle-class folks, but the price was so high, and of course, they wish with all their heart that it could have been, could have been different in the short term, but the long-term problem, unfortunately, he's not the only one. This is somebody I just happen to know. There's a well-known story of a young man who did a GoFundMe account to try to raise his money for insulin for the month. He came up $50 short, and he too passed away.
In Indiana, the private sector competes for Medicaid HIP members. Do you see Medicare for All seeking a private-public sector blend? Can you explain what HIP is first?
Sure. And as Reverend Martinez mentioned, my day job is I work at the law school, but I and we have one of my illustrious former students in the back, Laura. But most of what I do at the law school, my core duty is a clinical teacher, and that means the students are representing their first ever clients, and their first ever clients are low-income folks. We work with in conjunction with Indiana Legal Services doing that, and so a lot of our folks are on what's called Healthy Indiana Plan, but some of our students are on Healthy Indiana Plan. Healthy Indiana Plan is Indiana's version of Medicaid expansion. We've renamed it, and we've added some elements to it that are different from other states. So I'm sorry, the question about it.
Yeah, so do you think Medicare for All could seek a private-public sector blend?
So there's certainly talk about that. And to really, again, I think it's a wind at our back good news. Medicare for All is definitely a talking point. Now the question is, what does it mean? And sometimes the idea is, we need to have something like the Medicare Advantage program, which involves private companies, or the Medicaid program in Indiana with Healthy Indiana Plan expansion, which involves private health insurance companies. I can tell you on behalf of the folks we represent who don't have care, whatever, right? For short-term, for whatever it takes. But in a broader kind of, to put on the health law geek hat for a moment, if we keep that for-profit element in the middle, we're always going to have really expensive care because we are paying for the most inefficient system in the history of the world with huge CEO pays, huge profits, et cetera, which the rest of the world doesn't. So certainly philosophically, in terms of the perfect world, we don't have the for-profit insurance companies in the middle draining resources. But if the deal tomorrow is that everybody gets access to health care and that's the deal that has to be cut in the short term, I don't think you can be a reasonable moral person and say that we're going to say no to the people who need it. So who knows what will come out in the wash. The good news is that kind of discussion is going on right now.
So how much inefficiency does our present system have that could be freed up by a single payer system?
Right, there's different analyses out there, but the Medicaid program, Medicare program, excuse me, and there's a reason why the single payer proposal is usually called something like Medicare for All, because most of us who have Medicare, I don't have it yet, but look forward to that day, mostly like it. And it's not perfect, right? It has deductibles, has co-pays, and folks struggle to afford, especially high-end medicines on Medicare. But people who have Medicare like it. It gives us flexibility and freedom. It's a card. We go to whatever provider we want to. The Medicare program is enormously efficient in terms of like overhead cost of single digits. There's different numbers you look at, but 3-5%, something like that. While private insurance is much less efficient, right? Sometimes 20+%. You see some numbers that are even higher in terms of overhead. Again, it's easy to figure out because the private insurance company needs to pay for, needs to have profits, needs to pay return to shareholders, needs to pay and compete for really high-level executive salaries, and then spends a fair amount of money and time processing claims and contesting claims because it's in the financial interest of the for-profit insurance company to deny claims whenever they can. And so there's a huge amount that all translates into the cost we pay that wouldn't be there if we had a single payer system.
This question is a follow-up to that, and that is, if you have knowledge about this, would you share your thoughts on the efficacy of the competitive German not-for-profit insurer model, and what potential suitability that'd be here in the United States?
Yeah, I think that could be a really important possibility for the United States. I don't think it's necessarily ideal because I still don't know why we would want to put another entity in the middle of that pipeline. But the not-for-profit insurance model is not something that we're not used to because we've had that in the United States, right? We used it, the Blue Cross Blue Shield system used to be that, a not-for-profit insurance model, which was, again, enormously more efficient than what we have now because you didn't have to generate all the profits. So, yeah, it may be, again, I personally think on behalf of the folks that we work with who can't get care, in Alex's memory and other folks that we know who've struggled in the past, that I don't think we should reject any. I think the ideal is not to have anything between the single payer system, where our tax dollars go to our health care. But if we have to make compromises in, the political system and the sausage that comes out of the legislative process, if it ends up with everybody getting care that we can afford, the sustainable, I think that we as, those of us concerned about this from a moral standpoint, you don't want to say no.
Pre-existing health conditions are usually the most asked, or questions about that are most asked about to political candidates running, but yet Congress won't even bring it up for a vote. So what do you think is a solution or a path towards fixing that?
Yeah. Well, I may be the only person in the state of Indiana who actually has some positive things to say about the current campaign ads. Because I think it is good that they're focusing on healthcare. Now, I don't think it's necessarily been truthful on either side about that, right? But it does show that we all care about that. And something like pre-existing conditions, by some measures, 50% of adults have pre-existing conditions. This means all of us either have them or we know somebody who has them, right? And to answer to how do we fix this, I think the Affordable Care Act is certainly not perfect. Somebody like Alec, tried to get his health insurance through the exchange, and it's still expensive. It still has big gaps. But it has made enormous strides, and Healthy Indiana Plan is a good example of that, the Medicaid expansion. But also as pre-existing conditions, because the current law is good on this issue. Current law is that health insurance cannot deny us on the basis of pre-existing conditions and shouldn't be price gouging us either. So the discussions, and I can't imagine that these 30-second campaign ads that are so positive and warm and fuzzy aren't making this clear, but the current discussion is the Affordable Care Act does protect our access to health insurance if we can afford it because of pre-existing conditions. Our state of Indiana Attorney General Curtis Hill has joined a lawsuit that challenges the Affordable Care Act that would dismantle the protection against pre-existing conditions. Some of the political campaign discussions are that when there's been legislation to repeal the Affordable Care Act, it hasn't had a replacement that would protect pre-existing conditions. Now you hear some folks who voted for that or say they want to get rid of the Affordable Care Act, and they say the replacement would protect it. So I feel good about this current political campaign season on that end, is that I think pre-existing conditions, I don't think whoever gets elected is going to be so unwise politically as to attack this protection that impacts all of us. Because it doesn't matter how wealthy we are, right? If we have if we end up having, major surgery or inpatient treatment or, cancer or something, we cannot, unless Bill Gates is in the room, we can't pay for that out of pocket, right? We do rely upon the current system for that.
Are there enough doctors and physician assistants and nurses? And if not, how do we address that?
Well, I may defer to Dr. Hale or others in the room who are providers, but from what I see from the place in the system where I see it's certainly there's a shortage of primary care docs and general internists and pediatricians, the folks, because frankly they don't get paid as well, and their jobs are much harder than folks who are subspecialists. But then the growth of nurse practitioners and physician assistants and RN provided care, et cetera, has seemed to fill in that gap. To me, that doesn't seem, for the folks we work with, it doesn't seem to be as much of a crisis as simply being able to afford it.
This question mentions House Bill H.R. 676. Are you familiar with that? Is House Bill H.R. 676 that reflects what Physicians for a National Healthcare Program has long developed and advocated? Is it the best pathway or model to follow to achieve healthcare for all in the U.S.? And can you say a little bit about what H.R. 676 is?
H.R. 676 is Medicare for all. It's a single-payer health care system that is supported by Physicians for a National Health Plan, but more and more and more members of Congress. And it's not uniformly supported even by folks who are on the Democrat side. So if the House of Representatives switch to Democrat control, it's going to be really interesting to see what happens with H.R. 676, because a lot of Democrats support it. I think both of our Democrat members of the House from Indiana, I know Representative Carson supports it, I think Representative Visklosky supports it. So it'll be interesting to see what happens if it passes the House. But yeah, I think that's the fixing the gaping hole in the pipeline. That's the one that just says, we're spending so much money. It's not like we're not spending money now, right? We're spending enormous amounts of government money on Medicare, Medicaid, VA, et cetera. Let's have that money go straight to healthcare.
We have a few more minutes, and I want to ask you this question so that you can help us think about what's next. What would be a realistic, sustainable first step for First Presbyterian or for the faith community here in Columbus to take towards a solution that takes place right here in Columbus? What would be a realistic first step?
Yeah. Well, I think that it's really important when we talk about activism to really be hopeful when we talk about realism, because again, that's why I tell the story about the poorest, sickest people in the world who were sentenced to death somehow managing to beat and overcome the forces of the most powerful nation in the world, one of the most powerful industries in the world. So then I do think that the current political climate, the ads show that the access to healthcare is not a Democrat issue. It's a bipartisan issue. It's a concern. Again, most of us in the state of Indiana are represented by Republican legislators in Congress, but at the State House as well. I think we need to talk with them, and we need to gather the petitions. There's an old-fashioned act: gather the petitions, go speak with them, have actions, tell these stories, show that there's support in the community for this. And again, I think when this wins, there's going to be champions from both sides. And don't neglect our representatives at the State House, because a lot of really terrific models on drug pricing in particular are coming from the state legislatures. Because the states are on the hook for Medicaid prices, right? And when the price of insulin goes up like this, our tax dollars, our Medicaid dollars go up. The price of Humira, the anti-inflammatory drug, the price of cancer meds, when they go up, we pay for it very directly. It impacts our state budget. So you start to see a lot more folks from both parties, very much often Republican leadership, fighting against price gouging on the pharmaceutical side. So we shouldn't neglect our legislators, no matter what party they're from, and go tell them this is something that's important to us. And the current model is broken, but there are proven fixes. Let's pursue that.
So would connecting with PFAM or somebody like that, would that help us connect with the activists that would raise those issues?
So we would be happy to see that PFAM, we'd be happy to be a resource. It's something that for better or for worse, I've spent way too much time on drug pricing policy, so I could help a little bit on that. But I think that what's most important is you come as the Social Justice Committee of First Presbyterian, as you come with indivisible Bartholomew County. You know, the lawmakers in Bartholomew County could not care less about what I think, right? But they care about what you think because you vote for them. And I also think that we are all imbued with, and history, social movement history has shown this. I mentioned a few examples. When we're coming from a faith perspective, we have extra power. We have extra power because we're not coming at it because we're doing this because we're paid lobbyists. We're doing this because we have a financial interest. We're doing this because we think we have moral investment in this. And that, again, cuts across all kinds of political boundaries and I think gives a real authority when the advocacy happens. So I'm thrilled that the Social Justice Committee of First Presbyterian has embraced it. And again, as you know, Presbyterian Church USA has no question. Again, almost every faith tradition is this way. No question. This is a moral question. This is not some kind of financial, economic question. This is a moral question. First, we figure out how everybody gets access to care. Everybody gets access to medicines. Back end, you can figure out who gets paid what. But first, we start with everybody getting care.
As we prepare to conclude, I want to remind you that we will have a reception immediately following. The room is right behind us. The way to enter through those doors is the Laws Room, named after William R. Laws, who also draws the name, or we get that name for this lecture series. On behalf of the community, on behalf of First Presbyterian Church, Professor Quigley, I just want to thank you for sharing your wisdom with us, and he will stick around. And so if you're able to join us at the reception, you'll have an opportunity to greet him and share your thoughts as well. Join me again in thanking him, and again, thank you.
Thank you.